Hi, I'm John Scobles with Thermology Health, and we're a spin out of the UK government's National Food Laboratory, and we're addressing one of the largest complications of diabetes. Every year, there are about 18 million diabetic-related food ulcers around the world, and this costs $100, about $150 million in healthcare costs. Now, if you just get one ulcer, it takes about 6 months to heal in the US. Treatment costs about $45,000. And the problem is a lot of these don't heal. So almost 10% result in amputations each year. So the worst part of this is if you get an amputation, lower limb, it's a major issue. These patients, 50% of them are going to die within 2 years. So it's pretty grim. Now, this isn't just a developing world issue. In the United States, every one of these icons represents a real person that's going to have an amputation this week in the United States. So what are we going to do about this? How does we need a solution? Right now, I talked to a doctor last week at Major Cleveland Hospital. So what do you think about screening? And he said, it's hard. It's very hard. If you want to screen right now, you can look for color change in the foot. But the problem is, if you have darker skin, it's very difficult. You can take a gloved hand, try to feel for temperature. But again, it's really hard to tell the exact temperature. Maybe use a little technology, a point thermometer, check the left, right foot, do comparisons over time, and that helps. But to do it right, you need to check hundreds of points and check it over 2, 4, 6, 8 weeks. And so your head's going to be spinning with all the different data points. So how do we solve this? At Thermology, we actually have accurate thermal scanning. We take thermal scans, we put them in the cloud, we do a full analysis, and then we can feed back data points to the physicians so they can address them directly. But why is this a game changer? First, it's proven. We know a thermal signature precedes an ulcer, and 90% of amputations are preceded by an ulcer. So basically, it's fast, it's accurate, and also it takes minimal training. Right now, instead of having a surgeon or a trained nurse do the workup, we can teach a tech in less than a half an hour to do these scans. So it takes a load off the facility. Also, treatment is very simple, and if it's detected early, you can solve these issues. So we can provide a 2 to 4 week advance notice before an ulcer forms, and then treatment is simple. You do oral biotics, you can do bed rest, or orthotics. So it costs about maybe $1,000 or less to do these treatments and prevent it from ever happening, whereas that 6 months, $45,000, potential amputation, maybe death. Now, this is a huge market. Just in the US and Western Europe, where we already have a presence, it's $15 billion. But we're focusing initially on the US SNF market, or skilled nursing facility market, because there are very high potential and very dense population high-risk patients. We already have established relationships and been doing field trials to test this out. Right now, we've been doing trials in St. Louis, Missouri. We have contacts in Ohio. If you take just those 2 states and the 2 states in between, about a $70 million potential, of which we believe we can actually saturate. So our strategy is to focus on these areas. We have a high concentration of high-risk patients, as I mentioned. We also have recurring revenue, and there is strong initial interest. We talked to 20 of these SNFs. All were interested in the solution. We wanted to speak to 7 in hopes of getting a couple trials going. All 7 of them agreed to a trial, and we've already started at 2 of them. And they're going very well, and unfortunately, we already have had some issues. We had a foregone position to have treated. Also, there's a lot of other reasons, economic reasons that they're very interested. One, if you're a payer, you can save $5,000 per average high-risk patient. If you're a SNF, $1,500 average savings, and if they reduce their ulcers, it puts up their quality scores. They get paid for all of their services at a higher level. If you're a doctor, you get $600 additional income with minimum work, and you can also bill separately for any follow-up services or care that you need to do. And we get a $1,000 license fee. So there are competitors, but we have improved precision, which gives us more confidence. We have less labor because of our AI analytics, and it's a longitudinal data play. Basically, the more data we get, the more accurate we can get. We get better feedback. Also, we have a scanning design, one in green here, so we can check the entire foot or even the body, and that also is non-contact. So you can actually get less cost contamination, and also it works with bed down patients. The main competitor who's actually raised $130 million for this issue, focused more on home care. And they have a mat system which only measures the bottom of the foot, but can miss half the ulcers. And you have to get the patient out of bed, which is very difficult. So we have a very experienced team with a lot of depth in this area. And so I know there's a lot of work to do, but I think we have the team that can do really well. And so where are we now? We had $5 million of UK government funding that we used to develop the project. And then we, with some additional private capital, we now have working devices and charter with those active trials I mentioned. We also have reimbursement, and we filed a pre-sub and expect to file it for FDA early next year. So we're looking for a $1.5 million raise in a convertible note of safe. So combined with the $225,000 JumpStart matching grant, we'll actually get through FDA clearance, do commercial launch, and refine a device and AI platform. So if you'd like to learn more and help us save some lives, we'd love to talk to you. Thank you.
Thank you so much, John. Thank you. And now we will open it up to just a couple questions. Any questions? Oh, in the back.
Hi, Daniel Dudley, Trailblazers. Sorry if I missed this, but I was just curious, what regulatory pathway are you on?
Okay, for the class one,
Okay.
we give them credit, so we're gonna do it in this stage.
Okay. Perfect. Thank you.
Or,
Another question?
My name's Evelyn Rizzo. My question is, I have a clinical background in prostate neuropathy, so does the nursing facilities, they're more interested in this for pressure ulcers, right?
some, yes,
Okay.
some.
So when they're bed bound, the benefit to them is that you could monitor, heal, or ulcerations from pressure.
Exactly, yeah, so right now, the reimbursement is more for diabetic foot-related ulcers, or garden-related foot ulcers. So that's where we're going in initially. And the trials, we're seeing about 20 to 30% of the patients in this typical nursing facility that has some high risk of that. However, there is a lot of interest in other pressure ulcers, and we are doing some initial scans, kind of looking into that. And the goal is that we would do the diabetic foot ulcers first, and then expand that care, maybe even offer that portion for free if they do licensing to the other, because that way we can do combination. Yeah, that would be kind of a second stage expansion of the same facilities.
Thank you.
Thank you.
Thank you. One more question? Okay. Yeah, we're good. Thank you so much, John. It's been a great talk. And up next, we have Stephen Burns from Light Institute.